Friends, and thank you for joining me again today. This is Dr. Breen from Medicine Journey. In this lecture, we'll talk about hyperkalemia. By the end of this video, you will be able to define hyperkalemia, to know the causes, to know the symptoms, to know how to evaluate patients with hyperkalemia, and to know the treatment. So as we know, normal potassium level is between 3.5 to 5 millimole per liter. We define hyperkalemia if the potassium level is more than 5. Some labs consider if it's more than 5.5. Now, we consider it mild if it's between 5 to 6.4, moderate if it's 6.5 to 8, and severe if it's more than 8. Now, what are the causes of hyperkalemia? First, it's very important to rule out pseudo-hyperkalemia. Pseudo-hyperkalemia, this happens if there is red blood cell lysis, and this can be seen with prolonged use of tourniquet, if there is prolonged fist clenching, if there is ongoing IV fluid and we took the sample from the same line or near it, or if there is delay in sending the sample for analysis. So it's very important first to rule out pseudo hyperkalemia, and this can be by repeating the level. Okay, so first confirm that this is true hyperkalemia. Other causes of hyperkalemia can simply increase intake of potassium or food rich in potassium. Actually, it's not that common because in normal people with the normal kidney function is not that common. But we consider like there is increase in intake if the patient has renal impairment and there is the patient is not compliant with the diet, okay, or if they are already on like medication that cause hyperkalemia and again there is no compliance of diet. So what are the food rich in potassium? We have many, but the most common: dates, we have nuts, fruits, especially banana, vegetables, and dairy products. So most of the foods are rich in potassium. Now, another cause of hyperkalemia, which is the also common cause, it's not the most common, but it's a common cause, if there is reduce in potassium exertion. And again, we see this if the patient has renal impairment. Also, it's very important to check if the patient on any medication that can cause hyperkalemia, which are again they are common. We have ACE inhibitor, ARBs, NSAIDs, potassium-sparing diuretics like spironolactone, amiloride, eplerenone. Also, if the patient on beta blocker can cause mild hyperkalemia, digoxin as well, and citrin, an antibiotic. What are medical causes that can cause hyperkalemia? And I have to think about them. So think about primary adrenal insufficiency, think about renal tubular acidosis type 4, and in general in metabolic acidosis there will be hyperkalemia except two conditions. RTA type 2 and 3, they come with metabolic acidosis, but there is no hyperkalemia. Actually, there is hypokalemia. And also using acetazolamide. So acetazolamide can cause metabolic acidosis, but without hyperkalemia. Okay, so metabolic acidosis usually there will be hyperkalemia except two situation: RTA type 1 and 3, and if the patient is using acetazolamide. What other medical conditions that cause hyperkalemia? We have rhabdomyolysis, if the patient has trauma, or like the patient comes with seizure, so we'll suspect rhabdomyolysis. If the patient has hemolytic anemia or hemolysis. Also, if the patient has tumor lysis syndrome, if they have bulky malignancy, or if they received chemotherapy, and like there is like other features of tumor lysis syndrome, but if like other features are there with hyperkalemia. So yeah, tumor lysis syndrome can be one of the causes of hyperkalemia. Also, hyperglycemia can also accompanied by hyperkalemia. So these are the main causes. Now, clinical presentation, actually hyperkalemia, same as hypokalemia. So both will affect the muscle and the heart. So muscle, the patient will have weakness, paralysis, paresthesia, and cardiac, they can have any kind of arrhythmia. So they can have also AV block or VTAG, VFib, asystole. Any kind of arrhythmias can be seen in patients with hyperkalemia. What's the sign that we can find it in physical examination in hyperkalemia patients? It's decreased deep tendon reflexes. Okay. Now, how or before approach to patients with hyperkalemia, we need to know what's the Ecg change in hyperkalemia, which is very important. So hyperkalemia can mimic myocardial infarction, simply. So, but the good thing that these change resolve after treating. So this is how we differentiate the true myocardial infarction from the effect of hyperkalemia. Also, hyperkalemia can cause sinus bradycardia, can cause peak T wave, prolonged PR, wide QRS, and many effect on B wave. Can be wide, can be flat, or can be even absent. Sine wave, which is very suggestive of hyperkalemia, and AV block or any kind of arrhythmia, VTAG, VFib, etc. This is the sine wave pattern, which is very suggestive of severe hyperkalemia. Now, how to approach a patient with hyperkalemia? First of all, as I said before, we need to confirm that the patient has hyperkalemia, true hyperkalemia. So you have to repeat the level. Okay? It's very important to do ECG to check if there's any Ecg change, because this will determine the next step. So in case of emergency hyperkalemia, we have to start the treatment before identifying the cause. Okay, so when to consider this is emergency hyperkalemia? If the patient is symptomatic, or if there is Ecg change, or if the potassium level is above 6.5. Okay, I will talk about treatment and in case of emergency hyperkalemia later on. Then just to continue the approach to the patient with hyperkalemia, after if it's not emergency to treat, then we have to identify the cause. So again, identifying the cause, does mean to take more history. So from history wise, check if the patient known to have chronic kidney disease. If they are known to have renal impairment, check if they are compliant with the diet, if they are following low potassium diet. Check their medications, because most of them they will be on medication that they might cause hyperkalemia. Also check if there is any progression of the CKD itself. So ask them about any change in the urine output, any decrease in the urine output, if they are having any uremic symptoms. If the patient known to have end-stage renal disease and the patient is already on renal replacement therapy, it's very important again to check if they are compliant with the medication, if they are compliant with the diet, if they are compliant with dialysis itself. So check when was the last dialysis session. If they missed any dialysis session, they will come with hyperkalemia, fluid overload, and many clinical problems. Okay. Also, if the patient is not known to have renal impairment and they have hyperkalemia, we have to check if they are on any medication that can cause. Okay. And it's very simple also to check if the patient is on any a potassium supplement, which is also common. Like if the patient has diarrhea, let's say, diarrhea, and they had hypokalemia, we start them on potassium chloride, and actually it took for a few days. Then the patient, like, we missed that the patient on potassium chloride for like some days, and now in the repeating lab they have hyperkalemia. So it's very important to check the medication whether they still on the potassium chloride simply, or they are still on IV fluid that contains potassium. Okay. Also, lab wise, if there's hyperkalemia, check the CBC, check if there's any drop in the hemoglobin. If you are suspecting hemolysis, you have to do the full workup. So centroretic count, which will be high, for LDH also will be high, haptoglobin will be low, and indirect bilirubin will be high. Also, if you think this is because of hyperglycemia, check the glucose. For sure, you have to also to check renal function. If you suspect the patient has metabolic acidosis, you have to check blood gas. And if from history there is suspicion of rhabdomyolysis, so send for CK and myoglobulin. Now, what's the treatment? So in case of emergency hyperkalemia, we have 2 lines of treatment. In case of only hyperkalemia without emergency, so we have 1 line. So in emergency hyperkalemia, the first target will be stabilization of cardiac membrane. Okay, so it's very important to stabilize the heart, the cardiac membrane. So along with treating the hyperkalemia. So for this purpose, we have to give 10% of calcium gluconate. Usually we give 1 gram, which is 10 ml of the 10% solution. And usually we infuse it IV over 3 to 10 minutes. We have to repeat it after 5 minutes if still there is persistent Ecg change. If calcium gluconate is not available, then we have another option, which is calcium chloride. Again, it's 10%, and the dose between 500 milligram to 1000 milligram, and we infuse it IV over 5 to 10 minutes. Again, we can repeat it after 5 minutes. If calcium gluconate is available, so start with it, because calcium chloride actually it can cause irritation and tissue necrosis at the site of IV, so we don't prefer it. And if we want to use it, we have to use it in deep vein. Okay, so in emergency hyperkalemia, for sure we need Ecg monitoring, because we will depend on giving more and more calcium gluconate, depends on the Ecg change resolution. Okay, so this is the first step in emergency hyperkalemia: stabilize the cardiac membrane along with giving something for the hyperkalemia. So treatment to lower hyperkalemia or to lower the potassium level, actually first, the fastest one is shifting the potassium into the cells. It's temporary solution. Okay, so we'll start with it because it's fast, but we need, along with this, we need something to remove the potassium from the body. What are the most common agents we use to shift the potassium into the cells? The most common one is insulin with glucose. Usually we give regular insulin 10 units mixed with 50 ml of dextrose 50% in water, and we infuse it over 30 minutes. We suspect the action will begin in 10 to 20 minutes, and the peaks of action will be within 30 to 60 minutes, and the effect will last for 4 to 6 hours. So it's very important to know that I gave this thing, it will start working after 10 to 20 minutes. The peak effect, I will see it after 30 to 60 minutes, and the effect will last for 4 to 6 hours. Okay, how much we expect the potassium level will be dropped with this regimen? Usually it's between 0.5 to 1.2. Okay, now when can I repeat it? I can repeat it after 2 to 4 hours. It's very important to monitor glucose level because there's risk of hypoglycemia, so monitor every hour for the next 6 hours till the effect finish. Okay, usually if the patient is known to have diabetes already, the glucose level is 13.8, which is equal to 250 milligram per deciliter. So here don't give glucose, don't give dextrose, just you can start with insulin, but again you have to closely monitor glucose level. Another regimen or another medication that can be used to shift the potassium into the cells, we usually use, along with insulin with the glucose, we use inhaled SABA. But you have to know that this cannot be used as monotherapy because it's not that effective, and the effect or the big effect will take longer. It takes about 90 minutes to be achieved. Okay, again, if we start the treatment to shift the potassium into the cells, we have to give another thing which will remove the potassium from the body. So it's very important to remove the potassium from the body. So usually we have many ways. First, through the GI tract, we can give sodium polystyrene sulfonate, which is usually 15 grams. It can be given up to 4 times daily, oral. Or we can use calcium resonium, which is 15 grams, 2 to 3 times daily, and we continue using it till the potassium is less than 5. Then we can stop. Also, there is Batterimor, 8.4 grams daily. So one way to remove the potassium from the body, to start resonium, sodium resonium or calcium resonium, or Batterimor. Okay, another way, dialysis, and usually we use dialysis in refractory hyperkalemia if it's not responding to the medical treatment, or in severe renal dysfunction, or if the patient is already known to have interstitial disease and he or she missed their dialysis session. Okay, we can arrange for dialysis. Now, in case of fluid overload and renal function is not that severely impaired, here we can give trial of diuretics, lobe diuretics or thiazide. Now, in case of severe metabolic acidosis with pH less than 7.20, we can give trial of sodium bicarb, and again it's not effective as monotherapy, it should be along with the others. And usually we can give sodium 150 milliequivalent in 1 liter of 5% dextrose in water, and we infuse it over 2 to 4 hours. Okay, so these are the main treatment we have for hyperkalemia. Again, in emergency hyperkalemia, we have to stabilize the cardiac membrane by giving calcium gluconate first. Then we'll start treating the hyperkalemia, giving insulin with the glucose and inhaled SABA, or if refractory or severe renal impairment, we can start with dialysis directly. Okay, and if we start with shifting the potassium into the cells, we have to give along with this agent to remove the potassium from the body. So usually we give calcium resonium or sodium resonium. Okay, and in some special case, if there is fluid overload, the patient doesn't have severely impaired renal function, we can give trial of diuretics. And again, if the patient has severe metabolic acidosis with pH less than 7.20, and we can give sodium bicarb, 150 milliequivalent in 1 liter of 5% dextrose. Okay, so these are the main. If there is no If there's hyperkalemia but there is no emergency, we can start the medical treatment again, insulin with glucose and inhaled SABA and calcium resonium. Okay, no need to give something to stabilize the cardiac membrane. So these for today. I hope you get the benefit you want. If you have any question, just leave it in the comment. I will try to answer. Thank you so much. See you soon with another video.